Thanks for letting us do this, letting me do this. I wanted to do this topic for a while, and it is kind of a hot topic, even though these guideline changes have been out for a few years. It's been a little while, but the uptake hasn't been as good as hoped. And there's also some goals of us in that do this to get it out to like WIC and nutritionists and early childhood education. And that push is part of why I initiated wanting to do this talk. So my name is Brian Bizik. I work at Terry Riley, headquartered in our Nampa office, but we're all over. If you're familiar with Terry Riley, I think we have 13 clinics now. My background, I was in nutrition before I went to PA school. I taught at Oregon State University. I have a master's in nutrition from there, and worked at WIC. I was a WIC nutritionist for a few years in Oregon, in Salem, and then went back to school. And so now I work and do a lot of asthma and allergy. I get to do the pulmonary side of things as well. So that's been my focus for the last 15 years or so. So that kind of brought me to this. That's some of my things I do, and I really don't have any conflicts of interest with anything here. I don't have any conflicts with peanut butter. I do not own stock in peanut butter anywhere. But I will promote peanut butter today, but I don't make any money. So here's the objectives. This is going to be probably about 35, 40 minutes total. It's going to be quick. I have a lot of slides that are reference. I just want you to see it. If you're a clinician, that data may be helpful to you, so you can go back and look at it, data mine it if you want. If not, I'm going to go over them pretty quickly. So, it's just the data is there and it's helpful, but I'm not going to spend a lot of time on each individual trial. I'm not going to do that. The goal is to set the stage for how we got here. Why are we here? Why is this important? My goal, and I'll say this many times, is to impart the need, the absolute urgency of this, and just that waiting is not okay. And we just have to do a good job. If you're in doing clinical medicine, you're at WIC, you're a nurse, and you have an opportunity to talk to parents of newborns or toddlers, this is critical. And I'll going to build the case for why that is so. All right, that's my goal. And do talk about the guidelines and where we are now, and a little bit on the barriers of this, and then we will talk about the how-to. I have lots of references at the end for resources, things you can download. I have stuff, if you're a clinician, I have stuff from the FAMPIT site. The very last slide is from the FAMPIT site, which is run by Dr. Pistiner at Harvard University, about what we can do as clinicians and how to approach this and even how to bill for it, all that. So all that's coming, but my main goal is to plead my case that this is urgent, necessary, and the impact cannot be understated. So that's what I'm gonna do. All right, now we're gonna start with a story. I'm gonna go through this quick, but I think this is so many things in science are not, they're just happenstance. They're fun things that happen. So story about families in Israel and what happened when they moved to Great Britain. 2001, Dr. Gideon Lack, who kind of started all of this, he from England, he was in Israel giving a talk, and there was about 200 physicians in the audience, and he said, "How many of you have treated a child with peanut allergy this last year?" And he said, these are his words, 2 hands went up. And he thought, if this was in England, every single person would have raised their hand. They were largely pediatricians, so he said everybody would have said something about it, and no, 2 hands went up. So he kind of thought, okay, there's some difference. And there had already been some talk about why there was differences in regions in the world. Why did there's peanut allergy seems like intuitively it wouldn't be different, but it was very different. So he realized that nearly all the doctors in England would have raised their hand. So after this meeting, some conversations took place, and he really felt like he wanted to study this. All right. And he thought the reason could be genetics, or it could be peanut puffs. All right. So, and I have some right here. If you want, send a self-addressed stamped envelope and I'll mail you some peanut puffs. These are only 4 years old, sitting in my garage. But like that came up. Like, well, kids here in Israel, they eat these bombas, peanut puffs, and maybe that's part of it. He wanted to study this, couldn't get funding. So there was a period of time where he wanted to look into this, and it was nobody wanted to back him. All right, now fast forward almost a year later, there's a peanut grower. Her name is Dee Dee Darden, and she describes herself as the wife of a peanut farmer. She was doing volunteer work with the National Peanut Board. She was in England, thought, I want to go talk to this guy, because she didn't feel like anybody was doing anything about peanut allergy. And someone had asked her at a meeting, how do you feel about growing something that could kill a kid? That's her quote. And it hit her hard. Now, it's not a very fair statement. There's lots of foods you could choke on or whatever, but still, that hit her hard. And when she was in England, she thought I would just go by and talk to him. She didn't have an appointment. She went to King's College and she just said, I want to go talk to him. And he said, this is his words. He said, I agreed to meet with her. I didn't know if I wanted to, but she was wearing a shirt that said, I heart peanuts. So he agreed to meet with her. Can't make this stuff up. All right. They met and she wanted to support him. And so, with money from the National Peanut Board and some other groups, there's a couple other groups, they did this trial. They did this data analysis. And this was it. This was the first data that there might be something significantly different between kids that grew up in Israel versus Israeli kids that moved to the UK. Very similar genetic background, but very different diets. And so this showed that there was about tenfold more peanut allergy kids in England. Aha, so something's here. With the publication of this, the next kind of story happened where it took a while, like 7 years later, the LEAP study. LEAP study is what I'm sure most of you have heard of it. If not, you're gonna see, I'll have the data in it coming up, but it's what changed everything because the LEAP trial, they took high risk infants. This is high risk kids. These kids had moderate or severe atopic dermatitis or eczema. Those terms are used interchangeably here, or egg allergy or both. These high risk kids were randomized, and one group got peanut, group didn't. The group that got peanut, 2% allergy ish. You'll see the numbers. The group that didn't get peanut, 14% allergy. So right there, giving them peanut early, the results were overwhelming, and undeniable. This is huge. We had this data from Israel that was kind of anecdotal, if you will, or looking back at medical records. Now we have a randomized controlled trial looking at this peanut introduction. Huge, huge, that's how we got here to the data. All right. So just kind of keep that in mind. Second story, quick story. All right. This one's made up. This one's made up, but happens all the time. So I just picked the name Jonah. I asked AI helped me with some of these slides. And AI picked Jonah. So I did that. Born with eczema on face and hands and arms. That's not atypical for baby, right? They tend to get on the face, arms, as we get older, it tends to be in the bendy parts of our skin, like on the AC fossa or the back of the legs. But babies often get it on the face. Topical creams help, but not completely. So still struggling with some atopic dermatitis, but we're not going to feed any peanuts. So old recommendations, don't give any allergenic foods for a long time, maybe not till 3 years old, like no peanuts, no egg, no milk till they're 3. And because that'll cause allergy, right? Well, his grandmother comes over, likes to bake, and they're careful not to let Jonah eat any, but she loves to hold him while she's baking. And lo and behold, some of the peanut protein on her hands gets onto this atopic dermatitis skin. And the result is that peanut protein, which could have been introduced through the gut and the diet, got into the skin. That's the problem. It's not maybe the problem, but it's a big part of the problem. That peanut protein enters the skin. It's picked up by dendritic cells in the skin. It's processed through the lymphatic system of the skin, and it's registered as foreign. This now becomes a foreign protein, and the whole process of presenting it, T cells becoming specific, B cells going through class switching, making IgE that coats the basophils and mast cells, which leads to peanut allergy. That's the process when peanut protein is processed through the skin and presented to the lymphatic system of the tissue of the skin. Same protein, same day, same kid, but now we're going to process it through the gut. It's picked up by dendritic cells of the gut. It drains into the lymphatic system of the gut. Naive T cells are turned into regulatory T, and you'll see these Tregs, these cells, cause a dramatic change in the exact opposite direction. If you want to look at it from like on the left, you got the cutaneous exposure, peanut goes into the skin, allergy. The other side, peanut is introduced through the gut, and you get this process. Now, first of all, that's fascinating. Like this dual exposure hypothesis is incredible. And what percent of food allergy is this way? We're learning. We don't know because obviously sometimes food allergy doesn't happen till later. But this is a big part of it. So, but what I want you to hear too is that this process of tolerance is not just it's okay kind of a process. This is an absolutely dramatic allergy suppressing process. It's just as dramatic as the other side in the opposite direction. When you introduce these peanut protein and egg protein, and you'll see the allergens, when they're introduced, they stimulate suppression of type 2 inflammation, which is on the left. This process can have wide-ranging effects, not only just allowing to be tolerant to the food, there's more. So just kind of look at that gray bar. We have atopic dermatitis or eczema. Some kids start this march where they start with atopic dermatitis, they end up with food allergy, asthma, and allergic rhinitis. This is the atopic march. And our goal for a long time has been, can we stop this march? Can we interrupt it in the beginning and then stop it? If we can stop it there, could we stop asthma? Could we stop allergic rhinitis or prevent some of it or reduce the impact? And the data is already yes, you can with dupilumab, which is Dupixent. They've shown that this can happen when you interrupt atopic dermatitis early on. So the goal is not only tolerance of peanut, it's maybe we could impact this atopic march and have a dramatic impact later in life as well. How effective this is, we don't know yet. So I don't know. I mean, we there's data that this works and it makes sense logically, but just when and where and how to do this. But this is part of the hope that we can do this. Okay, so quick review. That's my AI slide or my AI picture. I put all this stuff into ChatGPT and I said, make me a picture, and they got this very happy baby with peanuts and eggs and fish all around him. So quick review where we're at. Exposure to food proteins can prevent food, right? Can prevent food allergy. Through the skin, allergies begin. Through the diet, allergies stay quiet. Thought more than once about having that tattooed on my ankle. I haven't yet, but still thinking about that because it's super cool. So this is kind of where we're at, and that hopefully sets the stage from kids in Israel and bomb bust. By the way, this was the thinking is that that's the most frequently given peanut source of peanut for Israeli babies and infants and toddlers. That's kind of why the Bombas got the reputation. When we do this, you impact a lot with the kid's life, right? So when we prevent allergy, the effects can be for a lifetime. That's my second GI little AI picture. I don't know what's wrong with the spoon in that. That spoon has like a double. I don't know. But obviously he's dreaming of shrimp and peanuts, so that's good. So just imagine preventing peanut allergy with peanut butter, right? This isn't a medication. There are ways to do the oral, or if we're going to treat somebody with an allergy, there are peanut protein medications that you can prescribe to get them tolerant. But this we're talking about is just peanut butter because the burden of food allergy is very high. Um, from the caregiver point of view, this is overwhelming, right? You'll see, I'll show you some data, but parents talk about how this changes their life, about how they alter what they do, and they never feel relaxed. So, going to go through a few slides. This is my warning that the data slides coming up there's a lot of information, and I'm just going to point out and then move on just so you can see it. But this is hopefully helpful for you. Some of these things you may want to print out if you counsel kids or you counsel parents, this might be super helpful. So, this is just how impactful are food allergies when it comes to parents and what it does. And you can just see again at a glance, anxiety, fears trusting others, blame when something happens. The idea here is none of this happens if I provide peanut butter, right? That's what we're talking about here. We're talking about peanut butter preventing all of this. And hopefully again, it's starting to hit home that this is not a little thing, right? It's not a mild thing. It's just kind of a nice thing. When you talk to parents, 89% avoid some restaurants. Talk about changing family traditions at the holidays and other times. They don't do them anymore. Have intentionally missed a school function, and 45% have avoided airline travel. So the ramifications of food allergy are so big, and we forget about it. If you don't have a kid or you know somebody that has this, we forget. But the one thing that's consistent from parents is the constant vigilance. They feel like they're never off the clock. Everywhere the kid goes, go to grandma's. What do they do? What's there? School functions, school parties. What are we doing? Peanut air free zones, which aren't really needed, but that's still part of it. So this is huge. And if we could prevent this, like, can we do this? And again, I'll show you in just a second some more data. But so the pandemic or epidemic that we have, that's kind of the numbers that you can see for reference. This is just how many have food allergy, about 2 kids per classroom. It's about 8%. So it's out there and, we deal with it. These are the big 9. It used to be 8, but now we've added sesame. So we've got the 9 allergies and just kind of how frequent these are. If you're curious, just what percent have any one of these allergies. I wanted you to see that. This is really cool on just prevalence. So look at the upper left, peanut and 1 year. So of kids that have a food allergy, 20% of those kids will have peanut at year 1. And then you can see it grows, right? Because some kids may not have it initially, but they grow into it. If you look at something like milk, if a kid has a food allergy at less than a year, 53% it's milk. but then that gets less as they get older, right? And it drops by a little over half by the time they're teenagers. So this is just the prevalence of food allergies. This is looking at the kind of racial and ethnic differences in food allergies. This you get asked this. So if you get asked, you'll have something to refer back to. But so let's just look on the left where it says milk and 13. So of the kids with infants, toddlers, and pediatric patients, I'll just say it that way, that have milk allergy, 13% also have a peanut allergy. And so you can go across and see if they have one, what's the likelihood of another? Parents ask this kind of question all the time. So you need to be able to at least talk about this if this is the conversation you're having. How likely is it that we're going to have another allergy if we have this one? And there's some you could look at like peanut and sesame and tree nut. There's a bigger correlation. Those proteins are more similar, right? They look similar to the immune system. So that's kind of the numbers. This is just what happens. About 20 of those kids with confirmed food allergy, about 20% in any given year have a reaction that requires medical care. So this is confirmed cases. So it may be a little bit more than the background of some people that say it. How many kids say they've been bullied? 1 in 3, when asked this, they were asked of junior hires, have you been bullied because of your food allergy? 1 in 3 said, yeah, I've been bullied from that. This too, another way to look at this, if you look at kids with food allergy, how likely are they to have other conditions? So asthma, background population, 12%. If they have a food allergy, almost a third. If they have allergic rhinitis, 12.8%, 30% with food allergy. And then the other chronic conditions, 4% versus 10%. So in this case, just thinking back to the atopic march, if we're preventing something, might we be preventing other comorbid conditions that we're not even thinking of? So big impact there. And then food allergy costs. The number. This was done 2013. Oh, this is a long time ago. Because the last year the number was $5,000, $5,000 per child per year in increased costs if they have one or more food allergies. So, I mean, the burden's high, right? It's a lot. So the burden of food allergy is huge. Cost, loss of normalcy, stress. The entire extended family is involved. Intervention early can prevent this and maybe prevent some or all of the atopic march. That's the goal. Hopefully this cements at home that what we're dealing with is not something. I talk to people and a lot of times they put it kind of in the same category as talking about early weaning or just things that are kind of that you can talk about and are important but not necessarily critical. With higher risk kids, which we'll be able to kind of put them in risk category in a minute, but with those kids, intervening is critical, and the downstream effects and the benefits are bigger, I think, sometimes than we think. So I'm not sure. I thought I heard something. Is there any questions?
No.
Okay. All right. So opening stories and kind of what's going on and this skin presentation of proteins, and then a little bit more on the burden. So kind of take a break here and move next to just real quick a review on food allergy. And hey, Jocelyn, is the anaphylaxis lecture still available? Can they watch that?
Yep, it's still available.
Okay, so if you're not comfortable with anaphylaxis to whatever level you need to be, we did a talk on anaphylaxis. So this is just a couple of notes from that. So what is a food allergy? What we're talking about today is a food allergy. It's IgE mediated, meaning it's this allergic response that causes a rapid onset of symptoms. Not immunologic ones that are different or that are important, but not part of this. Lactose intolerance, gluten sensitivity. So those are very different. A lot of people think they have a food allergy that don't. So we're just talking about IgE mediated. Too much on the screen. It's just for reference. Remind me some of the symptoms that I might see if an infant consumes something and they were to have a reaction, what might that infant present with? And you can see some of these things that you can get. This is pretty much any age. I have an infant one in just a second. But so this just kind of shows you what can happen when a food allergy, when it happens, you can get multiple body systems involved. So quick definition, potentially life-threatening allergic reaction that occurs within seconds to minutes after exposure. and it needs to include one or more, I mean, two or more body systems. So the way, is this a mild reaction or severe? The key is the number of body systems involved. If you have, they consume something, a food, and there's just some skin, so just maybe some urticaria, some hives on the face, maybe a little bit of hives or redness on the upper chest. That's skin and skin only. So that's one body system. With anaphylaxis, it's when you have two or more body systems. So if you think about the different systems, maybe they have a cough. If somebody has eats a peanut, they have some hives, and they cough, that's anaphylaxis. If the cough was due to it, I mean, if they were already coughing. But if that cough is due to that exposure, so you've got hives and coughing, wheezing, tongue is getting enlarged. That's two body systems, and that's anaphylaxis. Doesn't mean you have to give epi that second, but if you talk, go to my watch that talk, you'll know that that's the right thing to do every time. There's other symptoms that you can have, but the key here is this: that we have a likely exposure or confirmed exposure. In this case, we would have an exposure because the parents are introducing these foods and in front of them, their baby is changing. Just hives, we'll talk about it, but at that point you stop that food and you make an appointment. If it's two or more organ systems, skin, respiratory, GI, those three are by far the most that you're going to see with kids, then it's an anaphylactic situation, and then you're going to want to intervene like anaphylaxis. Now, you don't have to have all of this going on you don't have to meet all these criteria to give epinephrine, but that's kind of for the providers. I mean, if you have, even if you don't know there was an exposure, but you're seeing this happen in front of you, providing epi is always okay. It's never contraindicated, and there's no downside to giving epi except you may be giving medicine they don't need, but it's safe. Okay. There's the nine again. I don't know if that do that in there. When it comes to what our roles are, how are we going to do this? If we all have to do this. It's like we all have to be every one of us has to kind of move parents along this line, and if they need to be reinforced at every turn. WIC is a great example. So we need to every time we see them, ask them about it, reinforce the guidelines that we have, trust, build trust with them and educate early and often about the introduction to foods, provide support during the process. This is tough. In fact, when I get to the EAT study real quick, you'll see that even when parents were coached, it was a struggle to get parents to do this, to provide these. And this is not an easy process necessarily. So for the high risk kids, we need to be very proactive. This is what's happened in the past with allergen avoidance. You can see the rise in food allergy was significant. And so here's kind of what we know historically. And I get asked this a lot, so I thought this was helpful. What doesn't work? Avoidance of allergens, we know, doesn't work, right? Restricting maternal diets prior to birth doesn't work. Restricting maternal diets during breastfeeding doesn't work. And I just had literally 2 weeks ago, a physician had been giving, I mean, the advice was to this breastfeeding mom to avoid milk and peanuts, and they had avoided egg because the child had some atopic dermatitis. And that's not good advice. That's terrible advice. There's no correlation. You don't need to change mom's diet for breastfeeding. Even if there's a known food allergy confirmed, that's a little bit different sometimes, but even in that case, it's usually fine. And hydrolyzed infant formulas, they don't work. They're unnecessary. All the guidelines are clear that doesn't make a difference. It doesn't make a difference with atopic dermatitis or food allergy. So there are some exceptions when they need it. If they need to have those proteins broken down into little small dipeptides and amino acids, that's fine. But most of the time, that's not needed. Um, okay, so here's guidelines. Let's talk about what we have, what advice. So we built the case for why this is important, how impactful it is. Hopefully that's making sense, that it isn't something that's just okay to ignore. And the urgency, I'll get to that in just a second too, but just how critical it is to start this and have those conversations before the baby is 4 months old and starting solids. The guidelines that we have, you can see what happened going, up until about 2010 when um, we ended up with some people questioning it, and we've got the NIAID guidelines that said, look, we have the LEAP study, we have the EAT trial, there's enough to start changing things, and then you have the guidelines for Americans, and finally the consensus statement. So if you're curious, what guidelines do we have and what ones can I read? The last one, the 2020, 2021 uh, combined guideline recommendation really is the most comprehensive and goes into it. And I'll show you those in just a second. And then the last thing was just last year, the follow up to the kids that were part of the LEAP trial. They're already getting to be 12 years of age. And so they've asked them, hey, how are you doing? And even kids that didn't eat peanut very often at all, they still had maintained that tolerance. So our early data is that if you do this as an infant, the tolerance is achieved, and that doesn't go away. It doesn't wane, and I'll show you a little bit more in that second. So, um, all right, so I'm going to go through these guidelines and these trials again quickly. If you're somebody that likes the data and likes to data mine and look at this, then you can do that. But I'm not going to spend a ton of time because you can see there's lots of information. LEAP trial, that was the big one. It was the first one that really looked at this. And you can see on the bottom left where it says consumption 3.2 and avoidance 17. In these trials, 3.2% ended up being allergic that had that they ate peanut. Those that avoided it, it was just over 17%. So that was the thing that started all this, okay? The leap on just said if we continue, if we stop, I mean, for those kids initially, if we just stop it for a year, and then we recheck what happens. And in this case, all of the kids that stopped for a year and didn't have any peanut, the number of peanut allergic didn't change. The ratios were still almost identical. So at the point that they had achieved tolerance, stopping, it was from age 5 to 6, you can see stopping had no impact on tolerance. So that's good. They don't have to keep worrying about peanut intake. The EAT trial asked the question, is this safe? And what if breastfeeding moms do this? Will I impact breastfeeding? And so that's the data. If you want, you can kind of look at it. But in this trial, the problem that they had is that parents they couldn't provide enough support for some parents. Some parents just couldn't stick with it, and it really fixed in our minds how difficult this is and how much support needed. And part of the outcome of this was trying to work with groups like WIC to help support moms. This was the EAT trial. This was their kind of take home message. Early introduction before 6 months, of these allergenic foods did not negatively affect breastfeeding. And for those parents that could stick with it, there was a reduction in peanut allergy and food allergy overall. For those that couldn't, the difference wasn't statistically significant because but they didn't stick with the trial anyway with the program. How much in the E trial? Because we want to know how much. Okay, so we got to give a peanut or egg. How much? They found 1.5 teaspoons of peanut butter a week, or one small egg a week was enough to induce tolerance. So not much. Now these are infants, so that's still quite a bit. And how to do this, I'm going to show you. We're getting there, so don't worry about the how part. But this is the amount needed in the EAT trial. Some trials use a little more, but this worked really well. Okay. Then last month, if you saw this was on the news. We have the first data, and I didn't know this was coming out. I thought it was not coming out till next year. So this is great. We had the first data that just asked the question, is it working? Is all of this effort working? And this is published in Pediatrics. And I don't know if you can see it. Your pictures are covering up the data, but on the right side, I think it talked about it has the final numbers pre and post at before the guidelines and after the guidelines, and the reduction was significant. It wasn't as big as LEAP because this is just looking at just the guidelines, not looking at who did it, who didn't do it. But the change was significant, and this is tells all. So on the left is the blue or aqua line. That's the rise in food allergy prior to the guidelines. Then you have the guidelines, and then there's a period of time in there. By the way, there's 18 months that they're not showing you because there was a washout period. But after the guidelines, the red line. That's the impact. So this works, and this was so nice to get this data that really showed that it worked. This was on CNN. Advice to feed babies early helped 60,000 kids avoid allergy. So that's 60,000 EpiPen prescriptions that didn't get written. That's 60,000 birthday parties kids didn't have to miss or whatever. I mean, starts to put in perspective just the kind of impact we can have. I want to mention about risk, who's at risk. And this is right there on the side. You see the box. So who's at risk? Bottom box is just kind of average kids without any eczema or atopic dermatitis, no history of allergy for them or family members. Okay, they're kind of the base. The next rung up is anybody with a family history of food allergy. It's very low. In fact, and this is kind of the important point, mom has a baby, baby has peanut allergy. Then a year later, she has another baby. Is the second baby more likely to have peanut allergy than any other kid? And the answer is no. They're not more likely to have peanut allergy. They're more likely to have allergies, like just some allergenic problem. But that kid, the background risk is about the same, which seems counterintuitive, but it isn't. And it's kind of like a large local reaction. You have a large reaction to a bee sting that's, this big on your arm. The next one isn't likely to be anaphylaxis. Your risk isn't gone up because they're different processes. So in this case, family history of food allergy, it doesn't really change the risk. Now you get mild, even mild eczema. That's a higher risk. Moderate eczema, higher risk. Other food allergy for that kid. So the second child is born, the second child has an egg allergy. Then they are more likely to have another food allergy, but not before that. And then severe eczema, by far the highest risk thing. So this is what do we do with regular kids without any of this? These non-atopic kids, I'll show you, but the can't miss is those kids with atopic dermatitis. They've got it. They've got eczema. They've got a skin barrier that's compromised. It's cracked. There's fissures, and they have the genetic predisposition for allergies. That's a recipe for disaster because no matter what they do, some food proteins are going to get through that skin barrier, going to get in and get presented through that whole process of activation of T cells and B cells, and they're going to get IG. That's what's going to happen. So we've got to go after those. So that group right there, even if they have a family history of food allergy, does not increase the risk for that one, the next kid. Okay. So review. Adding peanut allergy reduced risk, approximately 90% in most of the trials. Once it was achieved, it persisted, even if the peanut was stopped. Introducing peanut and egg to breastfed infants did how it work for the parents that could do it, it did, and it didn't negatively affect breastfeeding at all. The amount needed, 3 times per week, 1.5 teaspoons of one egg. The risk kind of goes down. Remember, severe eczema is kind of the worst, then other food allergy, moderate, and family sibling in that order. And waiting till after 6 months or 8 months to introduce this is not okay. The 20%, it's a relative number. But every month after 6 months, that risk goes up by about 20% every month. Can't wait, right? This is the urgency is there. I'll see you at your 1 year well child check and we'll address it. That's not okay. That's not good. Guideline recommendations. This is the NIAID, and you can just see that if they have no eczema or food allergy, start introducing it 4 to 6 months. Moderate to severe eczema, we're going to introduce that kind of a more, just on significant like plan introduction. And then if they have severe eczema or egg allergy, they recommend a blood test. Now, I'm going to show you in just a second that nobody else recommends a blood test. These guidelines have kind of since been overwritten, if you will. American Academy of Pediatrics says recommend early introduction of peanut 4 to 6 months when they're developmentally ready. Dietary guidelines talk about nutrition, of course. Every bite counts, but at the bottom you can see it says add complementary foods, including allergens, at 6 months. So these are just different kind of guidelines that are recommended. The consensus guidelines, which Canada and then the two allergy groups, I have two groups that I report to in the Quad AI, and the second one in the middle is the college. Those two groups, they never get along, but they did for this, which was nice. I call them my two dads. They always fight when my dads are fighting. But they got together and even with the Canadians and agreed. And this is kind of the guideline that we use. Infants with eczema are at highest risk. Prevent peanut allergy and egg allergy by introducing between 4 and 6 months of age. Screening for potential food allergy is not required. There is no tests that need to be done, even if they have severe eczema, if you're doing it at 4 to 6 months. If parents want it, that's fine. Introduce all allergens when solid foods are introduced so that there's a diverse diet. Hydrolyzed formula does not provide protection. Don't recommend mothers restrict their diets. And breastfeeding is great, and we want you to do it, but just breastfeeding alone doesn't prevent food allergy, all right, in this one case. So, of course, do it, but just understanding what it does. This is kind of a clinic flow that you can get from FAIR. So FAIR is the food allergy research. You can see their link at the bottom. This is a lot, so I want to break it down into a couple parts. So let me just take the top and make it bigger. 4 to 6 months, almost all the kids you see, you can just do this. 95% or more. This is for every kid that doesn't have severe eczema. Provide these proteins to them in their diet at 4 to 6 months, okay? If they have severe eczema, that's eczema 20% of their body and is not responding to therapy, that's kind of how we define it. There's a bigger definition on the bottom right, and you can go to this website and you can actually see some examples. But severe eczema, you're not going to see that very often, but if that's the case, you can do blood testing. Not expecting you to. This would be an allergist normally. And so get them somewhere to do blood testing. But we're the only country that even has this as a recommendation. No other country says do this. They're like, no, don't wait because this is going to delay. Don't do it. Okay. So, and then when you see them back, if they're already peanut introduced, support them. And if not, provide guidance and talk about, why this is happening and hopefully move them forward. Again, just some data, it's a barrier. This is what patients have reported, why they didn't want to do it, why they don't want to give it to their kids, just kind of to be aware of what some of the resistance is. Here's some tips to overcome those. All right. So, how do I talk to parents who don't want to? So, for providers, education, getting some good resources, which I'll show you in a second, working with families, start the conversation early, improve access, allow them to come back and reach out to you if that's something you want to do. Identify affordable sources for these, provide resources, and review anaphylaxis and talk to them. It's very unlikely the child's ability to mount an anaphylactic reaction is almost, it's not zero, but it's very, very low at 4 to 6 months. They have the ability to have anaphylaxis, but it's not really, even if they're allergic, it just doesn't happen very often. So it is safe to do. And the benefit far outweighs any negative for most kids. And if they have severe eczema, you can get some help. Use shared decision making. I'm not going to get into this too much, but talk to what would adding peanut look like for you guys? How can you see yourself doing this? Getting them involved and trying to picture what it might be like to do this, encouraging them that it's safe. What happens if symptoms occur? So if they are doing this, you're talking to parents. They say, well, what do I do if a reaction? Okay, you're giving peanut, mild symptoms, again, one skin system. Okay, I mean, one body system. That's why I wanted to show you that before, is because this one body system, stop the food, and then you're going to make an appointment. If it's severe, two or more body systems, right? Skin, GI, respiratory. That's what you're going to see in infants. Stop, and it's anaphylaxis. So then you're going to do whatever it is you would do. Call 911. If you have epinephrine, maybe for a different kid, you might administer that. And I just put one slide about Neffy. Neffy is the spray epinephrine. If you're not familiar, I'm not plugging, I don't work for them, but it is a spray. It's very convenient. There's no needle. Having to convince grandma to give baby an epi shot, you have to hurt him to help him. Convincing grandma to do that is sometimes hard. This is a nice option, and the expiration date's a little longer. It can get frozen or hot. Doesn't break down like EpiPen. So some advantages there if that's what you want to do. Now, if infant reacts to the food, the family's going to be hesitant. You need to talk about that. And, if they're stuck and they don't want to go on and they don't want to do other foods, and get help with allergy. When you've done peanut and egg, that's the two big ones. Then we want to keep going and introduce complementary foods, check for readiness, start with one food at a time. Early in the day can be super helpful. Our own prednisone, our endogenous steroids, if you will, our own endogenous prednisone is at its highest in the morning and it's at the lowest at night, because if it's high, we don't sleep. So we have this circadian cycle with prednisone, and so it's highest in the morning. So our ability to suppress inflammation is higher in the morning. So it's just a good time, make it fun, and introduce it one at a time and monitor and see how they do. Some good signs. This is not my expert. We have a pediatrician that could get into this a lot more, but this is kind of what these consensus guidelines recommend. If they show good head and neck control, sits with support, they can do okay, but they can sit either alone or with some mild support. They're starting to put things in their mouth. They can grasp small objects, and ability to swallow pureed food. So they get, infants, we all know initially there's that point where they're pushing the tongue to the roof of the mouth and everything comes back out. At some point that starts to flip and they can actually move food back. That's another big sign of readiness. So whenever that happens, 3.5, 4.5, 5.5 months, that's when you can do it. This was my last AI image. It was just, I asked, this isn't good information. I just was funny because this is what ChatGPT said. Step 2, offer a tiny amount, pea-sized taste. I don't know. I thought it was cute. AI is not good. Strategies for success. I love this picture. This picture, this baby mom is a dietitian that does a lot of stuff for food allergy. Consider having a baby sit on your lap, let baby take control, dip a spoon and hand it over to them so they can kind of lick on it. Pureed foods or again, stuff that's safe. And then when they disengage, big part of it is if they don't look interested, it's not a punishment, come back and try later as soon as they're kind of bored with that. How to introduce peanut itself. This is from the National Peanut Board. Their website is preventpeanutallergies.org. So this just goes through and gives you some options for, okay, how do I do this? We talked about the amount. They're talking about 2 teaspoons. 1.5 teaspoons was fine in the eat trial. Giving it a few times a week, providing it. Number four is these peanut puffs. If you like, if you like that. All of these are good ways to introduce peanut. With egg, scramble the eggs, make sure they're kind of mushy, mash with water or breast milk. Hard-boiled eggs, can be choking, so make sure. And then for older infants, you can just, make an omelet where they can hold it and kind of eat it. That's fine. So these are just ways to get egg into the diet of these kids early on so they can see it through the gut, know that it's safe, and stop some of that inflammation. Okay, almost done. A couple more things. Moving beyond peanut, there's more. And when you give feedback for this course, if having more of the how-to, how do we do this? How do I present this? And I've got a couple slides, but if that would be helpful, let us know, because my thought was maybe in the future do something just on the how-to. Maybe review the science for 5 minutes and then get to the how-to part and have much more input from dietitians and pediatricians who do this a lot more. But there's lots of ideas here that you can do. Wheat cereal, baked fish, small pieces of shrimp or crab. Really want families to do what the foods they eat. Give kids the foods that parents eat. What's part of their culture? What's important to them? That's the foods we want the kids to have. A varied diet. Start with these other proteins and then quickly move to a safe, varied diet, getting it in that diet often. So small amounts given often. So early and often, that's just kind of keep going. You need to provide this, just like when we talk to patients, we need to touch them early and remind them every time. When the food, it's early and often as well. And so what do we do? All infants, this is just kind of the plan right there. You can read it. I don't want to go through it, but offer these foods 4 to 6 months. If they have eczema, if they have eczema, we really want that to start as close to 4 months as possible. So getting it early is just super critical, and they can do it if there's the readiness signs and it looks like it's a safe process from an immunologic standpoint. That's when we want to do it. Okay. Some resources, food allergy prevention is a good one. Solid Starts, I don't think that's a free site. It didn't used to be free. If it's free now, it might be, but I think you can get some stuff for free, but you also can develop menus and stuff. So if families want something, it has a really neat site. The toolkits that you can download, there's the reference. They have a good one in English and Spanish. So this is, what do I give? How do I look at it as a provider or an educator, and what do I give to parents? There's a good example right there from, and then when you get this, the food allergy prevention, they have some more things on on these videos on why, just kind of the same data I'm telling you, some practical tools and guidance for your clinic. So this is more clinician based. It's a great resource if you're interested. The three is just encourage and then evaluate how they're doing and keep educating on this and keep pushing it. If you do want to watch, I'll just go through these, but you can watch these. They're pretty neat reels about just kind of a review of what we talked about today. There's two of them. And these two, great resources. So FAIR, I do work for FAIR, so I'm plugging them, but they're nonprofit. The stuff they have is all free or very, very cheap. And you can go on FAIR and you can get a little stuffed peanut animal free too as well. And then the Center for Food Allergy, Asthma and Research, I don't work for them, but they've got a lot of really good data. They're from Northwestern, where some of those slides earlier, they came from out of there. Increased caregiver knowledge and confidence in early education. So again, just another handout that you can use. This is from Northwestern. Great stuff for parents that you can just give to parents to read. And then this is my last slide. This is FAMPIT. So FAMPIT is a clinician-based support system. If you're a clinician, this goes through. You can see at the top, what do I do for early education? How do I manage eczema? What about IgE-mediated food allergy? They have copy and paste into the EMR. They have dot phrases for EPIC. Really good. This is from Harvard. I don't know if that's a good institution or not. I've heard it's okay. So anyway, that can give you some information too if you're curious. And I'm 1 minute early, so I'll pause there. That was a lot, and I don't know if we have any questions or any comments from the panel as well.
Thank you, Brian. That was great. Getting a lot of applause there. I don't see any questions in the chat, but does anyone want to unmute and ask? Does anyone have questions? Hi, Irene. Yeah, go ahead.
That was awesome, Brian. I learned a ton. Can you hear me? Because my
Yeah, you're coming
internet's
through.
not great. Um, I loved your multiple food allergy chart. I'm so using that. And I want to get a stuffed peanut from Fair. So I am going to go to that website
It's a good one.
today. Um, I actually don't have any questions for you since you did such a good job. I actually have two questions for some of our panelists. One is for our pharmacist, is Neffy reimbursed by insurance now? And then for our WIC panelist, and then you, since you used to work for WIC, I want to hear what they're telling families because as pediatricians, we're all about the LEAP study. You know, we're on that at the 2 month, 4 month, 6 month visit, etc. You do have to encourage those parents because especially in some cultures, it just isn't done. And so you definitely have to have that conversation early and often. But anyway, those are my two questions. Thank you.
I actually can't answer your question about whether or not Neffy is getting reimbursed. I don't work in a pharmacy to see that end of it. I haven't seen it prescribed a ton, but I will reach out to our pharmacist to see if they've heard anything. Does anybody else have any other
Brian, do you know?
response?
I don't know if you have a.
It's covered pretty well. It takes a couple of steps sometimes, but it is covered pretty well, and you don't have to fail other options when it's covered. It just goes through, because that would make sense. You don't have to, it's not a step therapy. So I haven't had too much trouble, and they say they have a copay card on their site too. So, but I don't know if anybody else has any experience.
And then I can try to answer a little bit on the WIC question. So for part of it, we have to follow the guidelines that are set out from the AAP and then the USDA. And so whatever those guidelines say is what WIC should be teaching. We actually utilize a few of the resources that he showed us. With WIC, we've got the one from the peanut board, and then I believe another one of them that we've got as well. So we are utilizing those materials. I don't actually I'm at the state level, so I'm more of that level. But I do know we have quite a few dietitians in WIC on this call right now, and so they might be able to give a little bit of insight on what they're doing and not to put anyone on the spot.
I'm a dietitian that works directly with families, and we've been educating a lot. The dietitians have anyway, and we try to get them the first visit we have with them, which is pretty early. Sometimes they're 1, 2, 3 months old, and that's when we try to make sure that they know what to expect with the peanuts. I actually have a question, if it's okay if I add that here. A little confusion about the not letting it touch their skin first. I've been educating families to make sure it's by mouth the first time, but is that just with the children that have like the eczema, or is it any? We want to avoid the skin contact initially with any infant.
So it would be, yeah. So let me just say the consensus guidelines don't specifically talk about avoidance of, like steps to take to avoid skin contact. They just talk about this is what happens. And so when it's time, if you introduce it through the gut first, then you don't have to worry about the skin contact. But with that said, the kind of the practical guidelines that they give out, it says, if the baby has active, eczema, especially that seems to be symptomatic, it's bothersome, it seems like it hurts, it's red, there's some inflammation or skin cracking that you can see, that to avoid touching them. So it's not the hand or mouth. Letting them feed is just fine because at that point they would have seen those proteins through the gut, and there's a safety there. So I think it's a good question, and actually I'm kind of thinking we need to maybe address that a little bit more. But what would like at a 2-month-old or a 3-month-old, they have moderate to severe eczema. Do we take step? The one kind of practical guideline handout thing does talk about not letting the food touch their skin when it's symptomatic and when the erythema is quite bright. So that's a good question. And actually, yeah, probably need to add that in here.
Thank you. I know it got brought up, and I feel like it was at the NWA conference that I had attended. They had a whole allergy session, and they talked about avoiding that skin contact initially. So I educate that way, but I don't know, maybe I'm putting too much emphasis on it.
I mean, I bet. So they said, hey, listen, before oral introduction, prior to that, avoid skin contact of these proteins. That was the recommendation.
I think, yeah, well, yes, and they gave guidance like if you were going to, let's say you're preparing the peanut product and you're getting it all over your hands, and then you're handling the baby before you even sit them down to give them the oral. They were saying to avoid that, to wash your hands first, to not have those peanut proteins
Yeah.
on you. So I don't know. I've just been, I guess, being cautious and saying, hey, do it by the mouth
I
first.
think that sounds good. So this was for kids with eczema. So these were high risk kids, right? Yeah.
I'm assuming, yes,
Okay.
that this was eczema, and that's why I guess I'm trying to clarify that here, is if it matters if this child has perfect skin or
Yeah, I would think if perfect sin, maybe not, but I think with eczema that makes that's logical, and that's the practical handout that they have. It does mention that, so I think that's no, I mean that's good advice, and it's not particularly difficult to do. And if they have eczema, they just, especially if it's moderate to severe. I mean, if they really do have a lot of it, then they not only again they have the broken skin barrier, but they have that genetic predisposition towards allergy. Those are the two things that they have simultaneously that just shoots their risk up. So yeah, prior to oral, preventing that would make sense for those high risk kids.
okay, thank you.
Yeah.
So I have a couple more minutes for questions if anyone has any.
I was hoping that you could actually talk a little bit on, so one of the things that we did learn at the NWA conference that she's mentioning is if they don't have any severe high food allergies and with introducing complementary foods like such as fruits and vegetables, do they have to wait the 3 to 5 days between or not?
Yeah, I mean, I think the practicality of it is that making it a prescription, introduced A, 3 days later B, and it just isn't possible. And like I was telling you in the EAT trial, like it was just impossible for parents to follow these things. And so the big move has been to de-prescription diet, to take that out of it. And for kids that are low risk, that no allergy, no eczema, that introduce that need to wait 3 days isn't there's no data to back it up. So being careful, being reasonable, monitoring. If you gave a child, a food that had two ingredients or three ingredients that had a reaction, yeah, you do create a little bit of work because now we have to break it down and figure out which one it is. And maybe that's where you can do serum blood testing can be helpful in those cases. But so I mean the current guidelines is to know you don't need to do that in kids without previous food allergy when you're introducing those foods that are part of your life and part of your culture already, because it's not possible anyway. So just be careful, monitor, but you don't need to wait those 3 days each time for every single food after, because this is assuming they already have a quite varied diet at this point. You've made sure the other things, those high risk allergens aren't a thing, right? So no peanut allergy, no egg allergy. We've introduced these things and they're fine. Okay, now I'm going to do maybe applesauce with cinnamon. That's probably okay. You don't have to do applesauce and then cinnamon. It breaking it down that way doesn't seem to be helpful.
Thank you.
Okay, perfect. We only have 2 minutes left. So Brian, I don't know if you want to give us some last words and then I can close this out.
Last words. Well, I would appreciate your feedback if more on that practical side would be helpful, or maybe this is kind of cuts it. But thank you for doing it. If I can help, my name and stuff was on the end, or anybody on the panel, if we can reach out and team up to kind of get the word out, that would be great.